Hello. Hi, Tanya. Hi, Ariana.
Hi, how's everyone?
Good, thanks. How are you?
I
Can
think
you hear
okay.
me?
Can I just see if I can share, if you don't mind,
Sure.
before everybody comes?
You're
Um,
welcome.
ooh, suddenly it looks really funny. Okay. Can please let me know if you can see? I know it's not in presentation mode. I'm putting the presentation mode now.
Yes, I can
Yes.
see it.
Okay, that's fine. Everybody can see.
Yes, looks good.
Yes.
Thank you very much. Then I know it's working.
I'm
Share.
just going to see if I can share. Mm, let's see.
Yes, Tanya, I can see it.
Cool. Thank you.
Awesome.
To the Heme Deep Dive this afternoon. Today's deep dive is brought to you by Blood SA in collaboration with SAMBUS, the South African National Blood Service, and in strategic partnership with both the South African Clinical Haematology Society as well as the South African Stem Cell Transplant Society. I just want to give a shout out and thank our deep dive management team. So the deep dive team leader, Prof. Verberg, Dr. Khedian, who's our national training coordinator, and Dr. Nicole Smith, who's the national outreach officer. Just some housekeeping notes for this afternoon. So all our sessions are recorded, and if you go to the website bloodsa.org.za under resources and deep dive, you will find all of the recordings. We also value interaction. So if you want to add any questions or comments to the chat box during the presentation, you are welcome to do so, and we will respond to them at the end. In terms of CPD points, so CPD points will be submitted to the HPCSA for everybody who is a South African attendee that has registered. So you need to attend on your own registered Zoom link and not in a group. You need to attend for at least an hour, and you need to make sure that your HPCSA number is entered correctly when you sign up. If you have any queries in this regard, you can email admin@bloodsa.org.za. You can also join the mailing list via the website if you go to resources and then subscribe to Deep Dive. Otherwise, there is a QR code on the screen right now. And feedback is important for our speakers and for Blood SA. So if you can complete the anonymous feedback survey at the end of the Zoom meeting, that will be helpful. So before we go into today's topic, next week's topic also looks extremely interesting. Dr. Zinat Murad, who is speaking about from chemotherapy to bispecific antibodies, redefining follicular lymphoma treatment paradigms. Okay, but let's move on to today's agenda. A very interesting topic, not very common for a hematology deep dive, but it is a fecal microbiota transplant and its role in hematology. So let me tell you about my esteemed colleague, Dr. Rihanna Cochran. She is a PhD scientist who is trained in the field of medical immunology, and presently she is the head of the Department of Translational Research and Cellular Therapy at the South African National Blood Service. She has extensive experience in laboratory research in the field of infectious disease immunology, as well as stem cell research, management, teaching, and training. She has presented her research nationally and internationally, and she has received multiple national grants and awards. She's a committee member of national and international committees and working parties, and she really is the South African expert in this field. So we are very grateful to have her speaking to us today. Thank you very much. Rihanna, I will stop sharing, and if you can please share your screen. Thank you.
Thank you very much, Tanya, and thank you so much for that excellent introduction. Don't feel worth it. I hope everybody can see my screen. Can you just please confirm that you can see it on
Yes, we
presentation
can.
mode? Okay, it's looking good. And so I first want to thank Blood SA for this opportunity to speak to you today. It is really very kind of you to let a non-clinical person like me with a laboratory background speak about poop and hematology. I'm just going to pause my video. I know that there are some people that struggle with bandwidth, and I hope that this will help. So
Rihanna,
before we, yes.
sorry to interrupt. We can see the presenter view.
Oh gosh. Okay, let me just go back again. I think that I just shared
Sure.
the wrong screen. Um, Apologies for this.
All good.
Please let me know what you can see now. Still
We
the
can
same.
see, yes, there we go. Now it's in the proper,
Is it in the
perfect.
proper screen? Right.
Yes.
Apologies. I have two screens, and I think I shared the wrong screen. Okay, so we're ready to go. So before we start, let's just talk about what exactly is a healthy gut. I know that it was a lot of research that has been published in the last couple of years about a healthy gut and the importance of a healthy gut and the gut microbiome, and a lot of studies that went into what exactly is a healthy gut. So when you think about a healthy gut, is it from a clinical aspect, the absence of disease? Is it from a functional aspect to say, but there's no digestive discomfort? Or is it a holistic idea of that there's optimal structure, optimal function, and there's microbial diversity? What exactly is a healthy gut? When we think about healthy microbiota of the gut, the characteristics is mainly high diversity. And the high diversity is generally linked to resilience and health from an emotional, physical aspect as well. Balanced composition, so there must be beneficial as well, beneficial bacteria there, but there also must be a lack of pathogenic overgrowth. When we think of functional capacity, it's the ability to perform essential metabolic and immune functions, and these can be limit functional redundancy. When we think about metabolite production, these will be like short-chain fatty acids, bile acids, tryptophan derivatives, and all of these are crucial for gut and systemic health. And the other indicators could be, for instance, that the pH must be between 5.5 and 7. There must be a lack of inflammatory markers, and it must be resilient in terms of disturbances within the gut microbiome. So what influences our microbiota in our gut? These are a multitude of factors. They can be internal or host-related factors, and they can also be external. So when we look at the host-related factors, these are often genetics, age, and then yes, unfortunately, the older you are, the worse your gut microbiome is. The mode of birth, was it a C-section, was it a natural birth, as well as your immune status. When we look at external factors that can influence your gut microbiome, these can be diet. For instance, do you have a fibrous diet? Do you eat sufficient omega-3 fatty acids? Is there a gut? Does the short-chain fatty acids that's being produced assist in the gut barrier integrity? Then there's negative aspects of your diet, such as Are you having a lot of saturated fats within your diet? Do you have a lot of artificial sweeteners or artificial agents in your or emulsifiers in your diet? Because these can all reduce your diversity of your gut microbiome, increase your permeability, as well as an increase inflammation in the gut. Then there's lifestyle. Do you have a active lifestyle that will be a positive, while a more sedentary lifestyle can be negative? Are you on a lot of medications? Are you exposed to a lot of pollutants? And there we're specifically thinking of the heavy metals, because all of that influence your gut and your gut microbiome. So just to give you an indication of predisposing factors that can influence your gut microbiome, lots of alcohol, not very conducive to people watching the rugby match on Saturday, but yes, lots of alcohol can be a disadvantage. Probiotics may actually inhibit the entry pathogens from interacting with your intestinal microbiota. Antibiotics, we know, can disrupt our gut microbiome by killing harmful but also beneficial bacteria, and it thereby decreases the diversity of your gut microbiome. Chronic stress can lead to an imbalance of your microbial population and then result in dysbiosis. Of course, we spoke about environmental pollutants and toxins that can negatively impact your gut microbiome. We also know that actually a fecal microbiota transplant can alter your gut microbiome, so we need to include that. A sedentary lifestyle reduce the microbial diversity and an imbalance that can contribute to dysbiosis. And then low fibrous diet reduce the beneficial microbes that can also lead to dysbiosis. So what we eat, what we drink, what we do, how we work, how we rest, and where we live, basically everything. So how do the microbiota then regulate your health? So the gut microbiota performs very essential functions, and these include the digestion of complex carbohydrates, vitamin synthesis, immune modulation, and maintaining the gut barrier integrity so that there isn't the exposure of or the uptake of heavy metals or the uptake of toxins into the bloodstream. It also produces metabolites like your short-chain fatty acids, and that can reduce inflammation and it can support your health as well. Now, what happens when there's a dysbiosis or microbiota imbalance? So when you have a disruption of your microbial balance, this is often due to diet, antibiotics, stress, environmental factors like we just mentioned. And this can be associated then with specific clinical symptoms. There's a lot of discussion about what is causative, what is reactive, but this is just to give you an idea what it has been associated with. This is all obviously I got from literature. So it's inflammatory bowel disease, irritable bowel disease, obesity and metabolic disorders, type 2 diabetes, immune-related diseases, allergies and autoimmune diseases. And just to let you know that allergies and autoimmune disorders are often linked to early life microbiome disruptions and reduced diversity. Liver disease is another one, and then obviously neurological dysfunction. So dysbiosis often involves in the reduced diversity or the loss of beneficial species of microbiota, and therefore an overgrowth of your opportunistic pathogens. And this we specifically know with C. diff, but we will come to that later. So that there's other mechanisms also linked to microbiota and disease. So the gut barrier dysfunction, or the leaky gut as we call it, this will allow toxins to then and pathogens into the bloodstream, and that can trigger systemic inflammation. We have immune dysregulation, which affects your T cell balance. It can induce your Tregs. It promotes autoimmune and inflammatory conditions. There's a metabolic impact, which influence your bile acids, your lipid metabolisms, your energy harvest, which then, of course, contributes to your metabolic diseases, and obesity and liver diseases. Then you also have a neuroimmune axis, which is your microbial metabolites, and that can affect the brain function as well as your mood. This is just to show you that when you have a healthy gut and you have disease, the diseased gut can then return to a healthy gut. But there's a lot of questions that can be asked. So what do we say is a healthy gut? How many of these microbiota or different microbiota is meant to be there? What are they? What is the concentration thereof? What is the function thereof in health? Then can you predict the health? Can you predict if the person is going to be healthy or not just by looking at the microbiota? Can you predict if they're going to get a disease or not, or on the brink of getting a disease? Is this an early indicator of disease by looking at gut microbiota? Is there a causal link between microbiota and disease? So there's so many questions that can be asked in terms of the gut and the effect of the gut on the health of a person. That obviously, as you can imagine, the amount of research going on in this area is incredible. So what other interventions can we have to ensure a healthy gut? We know probiotics, prebiotics can enhance the beneficial bacteria and improves the immune system and the metabolic health. A fecal microbiota transplant will actually effectively reduce the recurrent C. diffs, and it can then challenge the donor cell, and it can recolonize the gut with all the correct microbiota so that the person leads a healthier lifestyle. There's also lifestyle modifications. As we mentioned previously, you have your dietary interventions, you have your sedentary life, and you have your lack of antibiotics or medication. Those, if you can change those things, it can also intervene your health and make sure you have a healthy gut. So let's just think about what exactly is a fecal microbiota transplant. So it's very simple. It's straightforward. You take a healthy donor, which will donate stool sample. You will test it, process it, and then that stool sample can be given to your patient which need it, either via the upper gastrointestinal route or via colonoscopy route. So it's a very simple way, and we will talk a little bit more about how we do this later on in the presentation. So currently, when do we use a fecal microbiota for? So recurrent Clostridioides difficile infection, or recurrent C. diffs as we know it. FMT is a FDA-approved treatment for recurrent C. diff. It has an efficacy of 80 to 90%, and that is supported by multiple randomized controlled trials and meta-analysis that were done. Those patients that do not, so those 10 to 20% of patients that do not react to the first C. diff transplant, or first FMT transplant for C. diff eradication, they often react to the second one. So sometimes you just need another donor. Not a second one of the same donor, but a second one of another donor. Then the delivery is a comparable success across the routes, either colonoscopy, capsules, enema, and you can either deliver it freshly, frozen, or lyophilized. So there's different ways in which you can actually then deliver your fecal microbiota when you do the transplant. Safety, it's generally safe. There's some rare occasions where there's some serious adverse event, but that's often linked to the donor screening that was not adequately done. What is new evidence or emerging evidence that's coming up? So if you have a sudden onset of C. diffs, the response rate is about 88%. Sometimes they need more than one transplant. Ulcerative colonitis, remission rate is between 30 and 50%. It's not diurnal, but without maintenance. The metabolic syndrome, as we said, there's a transient improvement in insulin sensitivity, but no sustained weight loss, unfortunately. And then irritable bowel syndrome, there's quite a lot of mixed results here. Some trials show that there's an improvement of symptoms, others do not. Then when we look at cancer immunotherapy, this resolves immune checkpoint inhibitors induced colonitis by 80%, and it may enhance the anti-PD-1 therapy response in melanoma. So there's other conditions, which is your chronic liver disease, your graft versus host disease, and we'll talk a little bit more about the graft versus host disease just now. Also, the multi-drug resistant organisms decolonization. They've also done quite a bit of research on autism spectrum disorders and neurodegenerative diseases such as Parkinson's and Alzheimer's. This figure is actually clinical trials that was registered in July 2023, just to give you an indication of the number of trials that's linked to fecal microbiota transplant. And as you can see, C. diff is by far the highest, followed by ulcerative colonitis, cancer, multi-drug resistant organisms, and a little bit of your HSC. We've got quite a bit more of graft versus host and hematopoietic stem cell transplants. Where did fecal microbiota start and where are we now? It actually started in the 4th century, where traditional Chinese medicine used to call it yellow soup, and literally had a very crude extract of fecal matter, which they literally just added water to and gave it to patients with chronic diarrhea to drink. It had some success, but not, obviously not very highly successful. This then developed into quite a lot of different scenarios throughout the years. But just to let you know that the first case of your FMT neurological disorders was done in 2011 with recurrent C. diff, the first randomized control trial performed in 2013, and the first randomized control trial for irritable bowel syndrome 2017. And then in 2022, FDA approved the first commercial fecal microbiota product, which is Microbiota. So as you can see, a lot of things happened for fecal microbiota transplant, and there's a lot of research going on at the moment. So let's look at safety. Is it safe to have a fecal microbiota transplant done? So there are some adverse events. These are mostly mild, which includes abdominal pain and some diarrhea. And there are sometimes severe events, especially if you've got multi-drug resistant transmissions, aspiration and perforation of the gut. Long-term risks are presently only theoretical, but these are highly contested because autoimmunity, if you are prone to it, you probably will get it irrespective, as well as some of your Parkinson's diseases and those sorts of things as well. Pediatric use, it's effective and safe for recurrent C. diffs. The donor age and the long-term microbiome impact, however, is unclear. And now today, let's talk a little bit about graft versus host disease, because this is very applicable when we look at our hematopoietic stem cell transplants and our patients that receive these stem cells. And what is the role of FMT in graft versus host disease? So firstly, we know that acute graft versus host disease occur within 100 days, chronic after 100 days. And there's different conditioning therapy, damages intestinal colon. So there's bacterial translocation, there's activation of antigen-presenting cells. There's the cytokine storm, which often is the major problem and results in a lot of tissue damage and other damage as well. So this is just a picture just to show you the healthy situation on the left-hand side versus the classical picture of your graft versus host disease on your right-hand side, with immune activation and influx of alloreactive immune cells, a lot of inflammation resulting in this. So let's look at what is the role of your microbiota during this stage. So because the microbiota maintains the gut homeostasis, it assists in the production of short-chain fatty acids and also induce your Tregs, your IL-10s, IL-22s, IgAs, which all strengthen your epithelial barrier. So this gut epithelial barrier is strengthened, reducing the possibility of graft versus host disease in the gut. So when there's dysbiosis, specifically after your hematopoietic stem cell transplant, there's often a loss of the diversity of your gut, and this precedes graft versus host disease, almost as if it can predict that there will be graft versus host disease. Then there's larger studies that can confirm that low diversity resulted in higher mortality and infections. And persistent microbiome damage can be linked to long-term complications, either cardiovascular disease or even secondary malignancy. So what drives the microbiome disruption? Often these are chemotherapy and radiotherapy, which we know our patients, especially with hematopoietic malignancies, will need. So chemotherapy and radiotherapy will drive microbiome dysfunction. Antibiotics drives it. Some other drugs will drive it. Immunodeficiencies will drive it, and diet, obviously. So when you have a healthy individual, if you have a patient with AML, after the first remission induction, cycle 1, you will have some of your diversity of your microbiota reduced. After your second cycle, even further reduced. And then when the allogeneic hematopoietic stem cell transplant takes place, you already have a reduced microbiome, which then could lead to graft versus host disease or the enhancement thereof. So let's look at the gut microbiome in your hematopoietic stem cell transplant. So the disruption starts actually before the transplant due to the chemotherapy and the antibiotics, as I've mentioned. And then during the transplant, the diversity decreases sharply. And often we have then pathogenic bacteria that then comes up and dominates the gut. That results in the recovery, and it's slow and incomplete. And sometimes it takes even a year for the gut microbiome to recover after this kind of domination of your Enterococcus and your Klebsiella and Streptococcus bacteria. So what is the clinical impact? Low diversity in the gut, pre and peri-engraftment, and this correlates with higher mortality, increased risk, and increased severity of your graft versus host disease, poor overall survival. The specific taxa association within your Blotia abundance is lower graft versus host disease mortality. Enterococcus more than 1% post-transplant gives you poorer survival. When we look at the microbiome targeted interventions, we can think about antibiotic stewardship. So rifaximin preserves diversity, broad spectrum antibiotics worsens the outcome. Dietary strategies, lactose restrictions may prevent Enterococcus overgrowth, but this hasn't been proved exclusively yet. Probiotics, there's a little bit of mixed results. There are some safety concerns, especially with bacteremias. And then there's a defined bacterial consortia, which promises in preclinical models. Also, you can do a fecal microbiota transplant. We know that it definitely restores the diversity post-hematopoietic stem cell transplant. There are case reports where there's small trials that shows remission in steroid refractory graft versus host disease. The risk is pathogen transmission, specifically multi-drug resistant bacteria and viruses, but this is often associated with poor donor screening processes. Then we have prebiotics and postbiotics, like fiber, oligosaccharides, short-chain fatty acid supplementation. These can all improve survival. This is just an indication again about your, on the left-hand side, a gut that is in homeostasis on the right-hand side, a gut with probiotics, FMT, and postbiotics and immunosuppressants that try and restore this. So what is the potential role of fecal microbiota transplant in hematopoietic stem cell transplant? Prophylactically, you can do a fecal microbiota transplant, and the aim is then to reduce your multi-drug resistant bacteria colonization and restore the diversity in the gut. And early studies show the feasibility and safety but there was not proven clinical benefit. You can also, for steroid refractory graft versus host disease, a case study has shown with using limited number of patients, only 58, 74% had an overall response and 57% of those were in complete remission. The best results were when it was used early and antibiotics were minimized. So for recurrent C. diff, high success rate, and it's even safe in immunocompromised patients. So the gut microbiota status strongly influences your hematopoietic stem cell transplant outcome. And the microbiome damage post transplant may be irreversible, unlike patients with antibiotic-induced dysbiosis and healthy individuals. And if it is irreversible, you need to have a fecal microbiota transplant to recolonize the gut with the appropriate bacteria. So just for interest's sake, I also looked a little bit about the melanoma immunotherapy. And the rationale there is that the gut microbiome significantly influences immune responses, and including deficiency of anti-PD-1 therapy. It's approximately 70 to 80% of the immunologically active cells that reside in the mucosal immune system, and they mainly enter the gastrointestinal tract. The microbiota metabolizes microbe-associated molecular patterns, or MAMPs, and that activate innate immunity and modulate adaptive immunity with cytokine production TLP17 responses. So what they observed was that patients responded to the anti-PD-1 therapy and have distinct microbiome profiles compared to non-responders. And certain bacterial species were enriched in responders, suggesting that the microbiota composition impacts immunotherapy success. So just to let you know, this is the clinical trial that they did. It was conducted in 2021. And it's only very limited number of patients, only 16 were included. And the inclusion criteria that after 2 cycles of anti-PD-1 therapy, were the only included in this trial. So 7 individuals had prior clinical responses to PD-1, 4 complete responses and 3 partial. And then they received a fecal microbiota transplant, and obviously the donated stool was screened for viral, bacterial, fungal, and protozoal pathogens. And the patient received a single donor FMT plus then pembrolizumab challenge. So what were the results? Response rate was 20%, 3 of the 15 patients completing it in 12 years. It was only a partial and complete remissions. And the safety, in terms of safety, the adverse events were consistent with the monotherapy, and no unexpected toxicity from the fecal microbiota transplant. So therefore, it is possible that the fecal microbiota transplant can overcome the resistance of the PD-1 blockade in a subset of patients. And this would suggest that the microbiome modulates a promising adjunct to immunotherapy. So again, this is not curative for patients in melanoma, but can be supportive. So now I'm going to go on about telling you a little bit about what's happening in the South African situation. So currently in South Africa, if you need a fecal microbiota transplant, it's very limited to only a few specialized centers in the private sector, and there is no fecal microbiota bank in South Africa. So what happens in other countries is they have a fecal microbiota bank, and then the clinician will just put a request in for a sample to be sent to them. A tested sample will be sent to the clinician, and they will perform the fecal microbiota transplant. So at the moment in South Africa, the gastrointestinal, the GI specialist that's performing these transplants asks the patient to get a donor, which is a family member normally. They would do the processing in-house in the rooms using a kitchen blender often, and then they would do the transplant fresh. So that is what's happening at the moment, because we don't have a bank. And this is where Sam is coming, but I'm preempting myself here. So when we look at a donor transplant, there's 3 things that we need to think of. We need to make sure that we select the right donor. We need to process the stool and test it properly. And then we need to give it to the right patient. So when we think about donor recruitment and testing, you need to do it via questionnaires. You need to do blood tests. You need to do stool tests. You need to continuously monitor the donor health, either via questionnaires or blood tests. When you look at the processing, the sample must be processed, it must be stored correctly, it must be tested and ensure that it's safe for the patient to use. Because we must remember that this product is going to go into a very ill patient. It's not going to go into a healthy patient. And then obviously the lab must also distribute it. The clinical applications, so the clinical side of it, the clinician will request the fecal matter for infusion, it will infuse it, and it will report adverse events and the patient outcome to the bank. So the bank will know, okay, this was a good donor, that was not a good donor, or yes, there was adverse events, or there were no adverse events, or what is the resolution of the disease or not. So as I preempted it, we at Sanbis, being a blood service, wants to go and start a fecal microbiota bank. And now a lot of people will say, but you deal in blood, how on earth can you start dealing in poop? It's not quite the same type of donation, which we completely agree. But however, Sanbis has a very unique opportunity to do this. We have experience in recruiting donors. We have experience in obtaining informed consent. We have experience in testing of the blood sample. We have existing infrastructure. We have trained staff. We have experience in biosafety procedures. We have highly efficient quality systems in place. And we've got an extensive logistics network. So we can get the sample anywhere where it needs to be. And we have access to blood donors. So blood donors are far more likely to become a fecal microbiota donor than an average donor. Our blood donors are used to voluntary, non-remunerated, give something of themselves. They give blood, and now we will just ask for something else, a little bit of poop. So they are a healthier part of the population, as we know it. They are generally, not all of them, but generally they are HIV negative, HBV negative, HCV negative, syphilis negative. So we know that they have none of these transfusion transmissible infections. They know what to do, they know what it's about, and they don't mind giving something for free. They meet our health and lifestyle requirements. And literature has shown that if you're a blood donor, you have a 20 to 30% chance to become a fecal microbiota donor, compared to the average man on the street, which have a 3 to 10% chance of becoming one. And this is because our donor criteria is far more stringent to become a fecal microbiota donor than what it is to be a blood donor. So we do a lot of donor screening. We have a health and lifestyle questionnaire, more extensive than the current blood donor questionnaire. You have to be between the ages of 18 and 60. A lot of people say no, 18 and 50. We do have very healthy donors at 60 still. Your BMI must be between 18 and 30. I know in Europe they say below 25, but other places in the world indicated below 30. So we decided, thinking of the South African population group, that we will take places like Australia and America, which does below 30. You will need to be subject to blood tests. That is the normal ones and like one or two more, as well as stool. And we will also do the stool testing. Then what is required from the processing facility? So firstly, it needs to be completely separate from other laboratories. The last thing we want to know is say that because we processed stool, it resulted in a bacteria in a blood product somewhere. So completely separate, physically separated in terms of It must be close to non-laboratory areas. They must have a separate airflow in and out of the laboratory, not share an airflow with other labs. The intake and the outlet must be above the intake and outlet of other laboratories. Obviously, very dedicated staff can only enter that with at a dedicated entrance. You will have a dedicated biological safety cabinet for the processing thereof, a dedicated -80 degrees to store your product in, linked to a laboratory information system that will ensure that we have all the criteria and all the tests, and ensure that when we have the results of the test, only then will the product be released for patient use. There will be several quality control steps in place, and we are at Sandus, we are extremely rigid when it comes to quality control. We will not let a product out of our hands if we haven't properly quality controlled it. Our risk aversity is quite high. Of course, there must be traceability. We need to know donor A gave patient B the product. If patient B has a adverse event, we need to be able to trace it back to donor A. Retest the sample that we gave, because we will always keep a separate little tube there, and see, is there something we missed or not. Then we will keep our records for 30 years because that is our standard practice. And as I just mentioned, we will always store a vial of the donation in the case of an adverse event. So our processing facility is very specific in terms of the laboratory requirements, the quality requirements, obviously dedicated personnel, highly trained personnel will also be in here. So how do we actually process it? The nitty-gritty of things. Firstly, we always begin with the selection, the screening of our donors. This will be, the donor will then donate a sample. The sample from donation to initiation of processing is between 2 and 3 hours. And then from donation to freezing must be 8 hours. So there's very specific time limits to this process, purely because it's a living organism that you work with, and we must make sure that we retain the majority of these organisms as we can. So the stool will be blended or filtered, and a solution will then be given to the patient. So before it will have microbial dysbiosis, and then following the fecal microbiota transplant, the idea is to reverse this and have a healthy gut again. So we always monitor for adverse events, outcomes, and alterations in the gut. So this is a very simplified process flow. You'll recruit donors, obtain informed consent, have the donor answer a questionnaire, test the blood, and give the donation back for them. They will then the donation will take place, and we will either have they can do a home donation, they can do an on-site donation, or they can do if there's a fixed blood bank, they can then do, and there's a bathroom in that donation. They can then do that donation in the blood bank. This will be tested and processed using visual inspections, weights, saline additions, homogenization. I will show you little pictures of that, filtration. We'll add the cryoprotectant, place them in the containers. And only after everything has been released and we know that everything is perfectly fine, they will then be released for use. So we have developed the questionnaire. We used international guidelines. This was adapted to the South African environment because, you know, certain things that they ask for internationally is not required in the South African environment, and vice versa. We have already obtained ethics to do this. So all of this is in place. So let me just show you what our first thing is how we're going to collect the stool. So we tested different sample collection areas. On the left-hand side, you will see it looks like a plastic holder that you put underneath a toilet seat, and then you put it. I can't explain anywhere else than like a large 1 kilogram margarine plastic container that goes into it, and then you will give the donation there. The second one on the right hand side is a plastic layer that you will fix onto on the toilet, but the problem there, it didn't work well, and sometimes it didn't stick well, and we do not want urine contamination within our stool sample, and that was a problem with the second one. So we decided to use the left-hand one for our purposes. And so I know a lot of times in the hospitals, they give you that little container with a little scoopy thingy in. I still don't know how you donate a fecal sample in it, but that's not what we're doing. We are having a proper container, which you can donate a proper sample. So what is our sample requirements? We must have a greater than 50-gram sample. It must be a type 3 or 4 on the Breston scale, which is showed on the right-hand side. And we obviously visually look for it to make sure that it's void of helminths. So we do a visual inspection. We will take the sample. We will obviously take a little sample for testing to ensure that there's no viral or bacterial contamination within your stool sample. We will weigh the sample. We will add appropriate amounts of saline, homogenize it. We will filter it, add our cryoprotectant, and freeze it. So when we look at the filtration methods, we also tried different methods here. One of them were on the left-hand side, we tried paper filters, different size papers, your Watton Fay papers, to see can we get it to filter. The idea of the filter is to get rid of the fibrous matter, because a lot of the time the preparation will have to go through an endoscopic tube if you want to do it either the gastrointestinal side or the colonoscopy side. So it has to be of a solution that you can actually get it through the tube. So we tested different papers, 4 sizes. It took too long to filter, and we have a time limit. So that didn't work. We tried the muslin cloth, which is a picture of them in the middle. It worked. Not as well. It worked. We could use it, but it wasn't as easy to use like we wanted it to. And then on the right-hand side, we use stackable sieves. So it's got a bigger pore size at the top, and then smaller and smaller and smaller and smaller pore sizes to get rid of all of your fibrous content in that matter. This worked very well. It is reusable. We have a laboratory washer or a lab washer to make sure that these are very clean. So it goes up to high temperatures, ensures that and we've got an autoclave as well. So we should make sure that there's no cross-contamination between different donors and donations. So I would like to show you in our laboratory, this is actually pictures from our lab. If I go from the top left-hand corner all the way through as the arrows indicate. So we will supply our potential donor with a donation kit, which include like an ice brick to keep it cold, the donation packet, the margarine tub, if you want to call it that, gloves, zip ties, a donation pamphlet, information leaflets, everything will be in the donation pamphlet. This will go on to, the donation will be made, will come to the lab, we will weigh it, add saline, and then we will homogenize it. And as you can see on the very far right-hand top row, that is what a homogenized product looks like. Currently in some of the practices where they use a fresh reinfusion, they literally just use a kitchen blender to blend it in. But I must admit, none of us in the lab wanted to wash that thing, so we invested in a homogenizer. We then would filter it using our stackable sieves, add our glycerol to it, put it in our containers, and put it in the freezer. We quality controlled every step of the process to ensure that we don't lose any of our microbiota along the way, and to ensure that we have an optimized process. So how far are we? We've completed the donor questionnaire, the donor information pamphlet. We've optimized the donation kits. The processing has been optimized. But unfortunately, at the moment, we're renovating the laboratory. So we can't, as soon as that's done, we're going to actively recruit our donors, get going, and be able to supply this to market. So just to summarize what I've said is that the role of fecal microbiota transplant, the established use is for your highly effective for recurrent refractory C. diff infections, and emerging use is specifically in hematopoietic stem cell transplant for your steroid refractory of graft versus host disease, which has a response rate of 74% overall with 57% complete remission. And it's, as I mentioned, it's the best is the outcome with early use and as well as minimized antibiotics. Multi-drug resistant bacteria decolonization is success rate of 70 to 80%. And then recurrent C. diff, it's consistent efficacy and safe in immunocompromised patients. So just to conclude, the gut microbiome integrity is a critical determinant for your hematopoietic stem cell outcomes. The FMT is most advanced intervention for microbiome restoration with proven efficacy in C. diffs and promising results in multi-drug resistant decolonization and steroid refractory graft versus host disease. So in future, the large-scale randomized control trials need to confirm the efficacy and safety of FMT in hematopoietic stem cell transplant, and the integration of FMT with dietary strategies, antibiotic stewardship, and then microbial metabolite supplementation is important. So the development of personalized microbiome is then based on interventions for hematopoietic stem cell transplant patients. These are the references that I used to compile the talk. And I would like to thank you for your attention.
Thank you very much, Rihanna. Thank you. Very interesting talk. Yeah, a fascinating topic. We're happy to take any questions or comments from anyone. I see Prof. Berg put a comment on the chat to say, this topic is tailor-made or man-made to catch our attention at the end of 2025. Fascinating topic. Yeah. So I think what's so relevant is that it's quite a rudimentary process, actually, if you see some other novel treatments, but really has the ability to be widespread and accessible to patients across the country. So we look forward to its implementation in South Africa. Are there any questions from anybody or comments? I don't see any in the group.
Are you going to do other, are there other microbiome in the human that you may also be building banks for? Are there other plans? Because as we know, there are other...
You're on mute, Rihanna, you're on mute, sorry.
Sorry, yes, Estelle, thank you. There are a multitude of other microbiomes. There are people that has like the vaginal microbiome to look at vaginal health and efficacy. There are a multiple of them, but at the moment we will just start with the easy obtainable ones, the easy donated ones. But we never know. We never know where it goes.
Oh, it's fascinating. I mean, yeah. So where do you think it will first be used? Clostridium, so probably.
First. That will be our first one, is Clostridium. And then obviously any of our other gut-associated challenges, diseases, syndromes. And then I also think it will be a great supportive therapy for our cancer patients, especially those that undergoes a lot of chemotherapy. The gut microbiome is destroyed. So it will be a great supportive therapy for them. It's not curative for them, but it will be a huge supportive therapy for them.
That's very interesting. Yeah.
I know that even the gastroenterologists that routine will use it themselves for C. diff are very happy to rather have a more established scientific reproducible method. So they'll be very happy to hand over their FMT requests and products for SAMBUS to supply rather than having to do them themselves. I think it's a last resort to get a family member and use a blender. but that's what you do when you're
Yes,
desperate, and that's what available. Yeah.
and it's just there's no testing done, which is what we want to do. We want to ensure that we supply a safe product. So with the appropriate testing. When it's a family member, it's often there's like no testing. It's, do you trust it? Do you sign consent for this patient, for this product to be used? And that's it.
And so can I ask you, with routine blood donations, obviously transfusion services test every single donation for viral markers, etc. For fecal donations, do you test, what blood and stool test do you do? And how often do you do them? Is it with every
So,
donation?
yes, so the literature, generally what they do abroad and now is they test initially and then they just do the donor screening. They've got a donor screening questionnaire every time the donation comes in, and then they test every 6 months. So initially they'll test blood and stool, and then only every 6 months. So we will have our testing criteria a little bit shorter and do it every 3 months. Unless something has changed, then we'll test it automatically again.
Okay, thank you. Dr. Parasnath wants to know, wants to thank you for the informative talk and wants to know when this will be available.
I really hope very soon. Our renovations has been delayed by another 3 months. So I can't wait for this to be available because we really need to get this going. I think there's such a lot of potential people that we can assist to get so better, so quick, so much quicker if we can get this product on the market. So I really hope very soon. But I don't have a definite
2026.
date.
Okay.
Yeah, sometimes 2026. Yes.
Okay, thank you. Michelle Bronze, hello. She wants to know, other than for C. diff, are there local gastroenterologists that are currently using fecal transplants for anything else? Other than those ones you read in the U magazine who are not gastroenterologists, but for people who want to lose weight and try an FMT from a skinny person. So yeah, maybe you can comment on that.
So, so the proper GIs, the gastroenterologist specialists, they mainly do it for C. diff. At the moment, some try and do it a little bit for ulcerative colitis, but mainly it's C. diff.
Yeah. So gastroenterologists really use it for FDA approved or very high evidence. Yeah. So C. diff and ulcerative colitis. Any idea of the cost?
That's going to be a very difficult one. We want to make sure that we cost it appropriately so that we know that it is well researched. And as you know, Sanders works for a fee for service costing model. So it's not as if it's unless you're going to charge what it's going to cost us to make. The biggest problem is our testing. That is our biggest cost driver. And at the moment, I'm not exactly sure. If I have to give a ballpark, it will be probably about, I would say, less than the cost of an apheresis platelet.
Yeah. And
It's,
compare
yeah,
that
it's
to some of
difficult.
the antibiotics to treat C. diff as well. So
Yes,
yeah.
yes.
Okay, thank you. There was another comment higher up, apologies, I missed it, which was what is the percentage more or less to the population requirement as compared to other products? I think if I understand this question, Grace is asking, compared to population who require blood products, what percentage of the population would require this?
It's going to be a very small percentage. Um,
Yeah.
so it is going to be very small. C. diff is not something that recurs all the time. However, the the impact on the patient is very high. So if we can even get this to a couple of patients, and that's why we said that we can't only treat C. diff patients, it's not going to be economically feasible. But if you have it as a supportive therapy for all your cancer treatment or your other transplantation treatments, that can then be more financially viable product to be able to put to the market.
Okay. Charlene asked the cost. She missed it. So Rihanna doesn't know, less than a unit of apheresis platelets. The biggest cost is the testing. Okay. Bikash asked about the role in FMT in steroid refractive GVHD. I think he's asking, is it to treat gut GVHD? Which the answer would be yes,
Yes.
if I understand that question. Okay, cool. Thank you. I think we have covered the questions. Yeah, if there are no other comments or questions, I see it's nearly 5 o'clock. So Rihanna, we look forward to your progress on this and keeping us informed. And I think also it's difficult to understand the demand for a product that isn't available because you don't use it because it's not available. And I do think that once gastroenterologists, other than the few in private who can do it themselves, once other people realize that it is available, the need or the demand may grow. Yeah, okay, sorry. Bikesh wants to know our experience and outcome in FMT with steroid refractory gut GVHD. Thank you.
So we don't have experience because we don't have the product yet. But so I gave in the talk, I did give the international published, what was published so far. So it does help. It does not completely 100%. I think that it was, I'll have to just check my slides. It was about, I think it was about like 40 or 70%. I can't recall now exactly. Yeah, so, but we're not exactly sure what is the curative rate there.
Yeah. And so hopefully we will invite Rihanna back in a couple of years to share our outcomes for FMT patients. Yeah. Okay, and Annette says very interesting. Thank you. Okay, well, if there's no other questions or comments, I just want to thank all of you listeners again. And Dr. Cochrane, thank you very much for this very interesting, slightly different talk. I think it's related to hematology in two ways. Number one, because the best way to implement a cost-effective, safe product that's widely available is to use a transfusion service or a blood service model, which is what you're doing. And number two, because I think there are definitely hematology related indications for it. And as Michelle asked, a very good question, but really what you see in the international literature is although there's one FDA approved indication for it, the amount of clinical trials for so many different indications is just growing. So yeah, really the role of the microbiome in so many diseases is not yet understood, but I think there's going to be more requests for it once for multiple indications. Yeah. So thank you very much. Thank you.
It was great to have you, Tanya and Rihanna. Wonderful. It was very, very interesting.
Our
A
pleasure.
very
Thank
good
you, Rihanna.